Thank you for those of you who are here in person and for those of you watching the recording. Tonight's presentation is going to be on glioblastoma, a form of brain cancer, and the genetics, genetic counseling, and patient testimony. On that note, I just will give myself a quick introduction. I'm just going to give an introduction on the importance of the topic and then an introduction for each of our presenters today. So for those of you who might not know who I am, I'm Rachel Baer. I'm the Director of Education and COO of Clover Genetics, and I'm just going to be moderating the presentation. I just want to talk about why this topic is important. Rare diseases and rare forms of cancer can be even more complex than the more common forms, and they frequently impact children and young adults, and the warning signs might be less frequently screened for. So raising awareness for conditions like these and understanding that there's not just one type of brain cancer, but many forms is critical for developing treatments, cures, and effective screenings. Another point to note is the different survival rates for different cancers of the central nervous system. So when we look at how rare they are, we can see that the survival rates largely depend on the type of brain cancer and when it's diagnosed. And that 1% chance is for all of the different types of brain cancers throughout a person's lifetime. So this is just briefly meaning to point out that there are many different forms of brain cancer. Each form can impact different age groups, cause different symptom types, and has a different prognosis and treatment approach. So gliomas are one of the most common forms of brain cancer, and that's the category that glioblastoma fits into, and which is what we'll be talking about today. And those are cancers that develop in the nervous system. They can be derivative of a couple different types of cells. So glioma is really just an umbrella term for brain cancers that form from different glial cells within the brain. And the types of cancers are kind of graded based on the cells of the brain that they most closely resemble. So glioblastoma is considered a grade 4 glioma. Today's presentation is going to begin by exploring the biology and genetics behind glioblastoma, or GBM, followed by, and that's going to be presented by Jessie. That is going to be followed by an account of genetic counseling for brain cancer indications led by Andy, and that will be concluding with a personal testimony from Drew, followed by a Q&A. So with that, I'm going to introduce our first presenter, Jessie. She is one of Clover Genetics Genomics Education and Advocacy interns, who we have been so lucky to have assisting us this year in developing educational materials, website enhancements, and other content and support. So she'll be presenting again on the background and biology of GBM. After that, we will hear from Andy, the Clover Genetics founder, and my favorite genetic counselor, who will detail what the red flags and concerns are and what a genetic counselor should look at during each step in a consultation with someone who's seeking support for a brain cancer indication. And lastly, my close friend Drew, who will be sharing his experience being diagnosed with and undergoing treatment for glioblastoma, and the specific immunotherapy trial that he's been undergoing at the Cleveland Clinic. So without further ado, I'll pass it off to Jessie.
Yeah, thank you, Rachel, for that intro. So hello, everyone, again. If you haven't yet met me, I'm Jessie, one of the GEA interns here at Clover Genetics. So I'll be giving a really brief background on the biology and genetics of glioblastoma, aka GBM. So what is glioblastoma, or GBM? It's an aggressive form of cancer that can occur in the brain or spinal cord, and it can progress throughout the rest of the nervous system as well, as Rachel had mentioned. It's considered one of the most common and aggressive malignant brain tumors in adults. So the GBM originates from cells called astrocytes that are connectors that hold the nerves in place. So if you look at the image kind of at the bottom, you can kind of see that the astrocyte kind of radiates almost like a star out of the axon into the blood vessels. So in GBM, once the astrocyte begins to take more of a malignant behavior, you can imagine how it can really rapidly start to grow and uncontrollably invade the connecting tissue and cells nearby. So what is the GBM prevalence and incidence? So again, glioblastoma is the most common. So it accounts for over 47% of all cases in total. It has an incident rate of 3.21 per 100,000, meaning that out of a population of 100,000 people, around 3.21 individuals will develop GBM. As for demographics, the median age of diagnosis is 64 years old, or in the 60s in general. There is a slightly higher incidence in males compared to females and in white individuals to other ethnicities. But I will say the caveat is that there's a lot of underlying causes that can um, come from these kinds of statistics. So there might be other kinds of risk factors or health disparities to also take in note um, for these incident and prevalence rates. So kind of delving into the different types of GBM, there's two really general types of glioblastoma. The first is called primary or de novo, and the other one, or the second one, is called secondary GBM. So for the first type, the primary de novo GBM, you can go to the next slide, Rachel. Sorry. This is when the tumor really arises without any kind of known precursor. So patient doesn't have any sort of past clinical or histological evidence that would have alerted them of GBM prior. So the vast majority of GBM cases are de novo, about 90%. And they're commonly found in older patients with a median age of around that 60 year frame. So that is primary de novo. The second type of GBM is secondary GBM. So this is categorized as a low-grade tumor that progresses over time into full-grade GBM. This secondary GBM is primarily found in younger patients around ages of 45 or younger, compared to the primary GBMs, which is the 60s. One decisive genetic indication of secondary glioblastomas is isocitrate dehydrogenase mutations, aka IDH1. If you recall, back to the days of undergrad biology or graduate school biology, I'm sure the Krebs cycle is very much ingrained. But in the Krebs cycle, there is IDH1, which is where that arrow is pointing to. And it's the enzyme that catalyzes the conversion of isocitrate to alpha-ketoglutarate. And we know that the Krebs cycle plays a really key role in cell metabolism as a whole. So if anything is mutated or is going wrong, that can cause a lot of problems with cell growth. So IDH1 mutations are particularly associated with an increase in uncontrollable methylation of the DNA. So this results in the silencing of key tumor suppressors and regulatory regions. So as a result, that leads to a domino effect of dysfunctional cell growth and can lead to brain cancer. So again, these IDH1 mutations are detectable because it is a genetic indication from an early point. So it can be a really clear way of identifying that low-grade secondary GBM tumors, which is not as easy with the primary one. To kind of address the heterogeneity of the tumor and taking the information into account for treatment, researchers have recently identified 4 different transcriptomic subtypes of GBM. They are classical, proneural, neural, and mesenchymal. And each of these subtypes of GBM have their own special gene expression landscapes or signatures. And as a result, this framework could provide us with more information on how we can categorize different individuals' GBMs and help us tailor their specific target therapies to what kind of specific GBM type they have. And current studies also show that there are 3 major pathways that are highly mutated or deregulated in GBM. So on that next slide, they're listed as the p53 pathway, the receptor tyrosine kinase RAS phosphodienosidide 3 kinase signaling pathway, and the retinoblastoma pathway. And there's also other pathways involved, but I would say from my research, at least these were the three major ones. I won't go into the nitty-gritty details of each, frankly, because as you can see from the figures, they're pretty complex and I'm not even entirely sure of how they work. But the point is, you can see like if any part of the pathway is kind of altered or mutated in any way, it can very quickly lead to like a domino effect. And in the case of cancer, it can cause the tumor cells to escape the cell cycle checkpoints that would that are in place for regulating proper cell growth and death. So what exactly causes glioblastoma? There's not really super clear answers at this point. There's a few known risk factors for GBM. One of the few known is ionizing radiation, and that's kind of a factor across the board for many different types of cancer. Some examples of ionizing radiation are heat or light from the sun, microwaves from an oven, X-rays or gamma rays, any kind of high energy waves. Other loosely associated risk factors include exposure to pesticides and smoking. As for genetic links, there is a slight increased risk of glioma development in some genetic diseases, for example, NF1 or 2, and Turcot syndrome, which I believe Andrew will go into a little bit more later. But as to what glioblastoma exactly looks like how does it manifest in a patient, or what does it look like on a day-to-day basis, depending on the area and size of the brain tumor, these symptoms may vary. So some common symptoms are worsening headaches, nausea, vomiting, and seizures, to really name a few. Patients can also sometimes experience issues with their vision or speech, hearing, and just general cognitive thinking. And those are some of the indicators that will lead people to try to reach out to a physician, and then leads to a glioblastoma diagnosis in the end. So how is GBM diagnosed? So this is done through a series of tests and procedures, the first of which is a very basic neurological exam, where a physician or provider will do a very general assessment of motor, sensory skills, a patient's mental status, and their basic functioning of their nerves. If any kind of red flags occur in the initial neurological exam, then the physician can escalate into referrals for imaging tests to more accurately pinpoint and identify like the location of a brain tumor. And that can be done through MRIs or CT or PET scans, which are all very similar. They just use like different kinds of energy beams from my understanding. And lastly, patients can then have a biopsy of the tumor done, where an actual sample of the tissue is extracted and analyzed for what specific kinds of cells are being affected. And at that point, it can also be a way to evaluate the level of aggressiveness for the tumor. So there are several different GBM treatments currently available, which I believe Drew will also go into later. So I'll quickly kind of go through some common ones. First of which is surgery, where the doctor will actually try to remove as much of the tumor as possible. Unfortunately, complete removal isn't possible, since the GBM, again, it really does like radiate out and affect the normal brain tissue as well. So surgery sometimes is paired along with other sorts of therapeutic options, which I will mention as well. Besides surgery, and then another option is radiation therapy, where again, there's that usage of high energy beams like X-rays to actually kill the cancer cells. The next option is chemotherapy, which involves drugs to kill the cancer cells rather than just energy beams. And there's many different types of chemotherapy depending on the actual progression of the GBM, as well as the desired like administration of medication. And chemotherapy and radiation therapy also can be paired together. Another form of treatment is these tumor treating fields, or TTF for short. So it's the usage of electrical fields to disrupt the tumor cell's ability to multiply. It involves, as you can see in the image on the right, it involves applying these kinds of adhesive pads directly to the scalp. And those pads will then emit the electrical fields, which is kind of interesting. And TTF is also commonly paired with other sorts of therapies as well. Another kind of subtype almost of chemotherapy is targeted drug therapy. So this is where drugs can attack specific abnormalities in the cancer cells and cause them to die through apoptosis. One common GBM targeted therapy drug is Bevacizumab. Brand name is Avastin. And it's designed to block a protein called vascular endothelial growth factor, or VEGF for short, which is found to be overabundant in cancer cells. So by blocking the VEGF, it prevents the growth of new blood vessels, including those that feed the tumor. Additional sort of treatment that's usually paired along with some of the very intensive, like physically intensive treatments, is palliative and supportive care as well, that really focuses on providing relief from the pain and other symptoms of really many different serious illnesses. And then lastly, there's still a whole world of clinical research and trials that are looking to provide new therapeutics to treat GBM, which I believe Andy will speak to as well. So I did want to pause and just ask if there's any questions that I can help with about like kind of the general biology behind GBM. I'll say I'm not a medical professional by any means, but I'll be happy to try to answer any. No? Okay. Elsewise, I will then hand it off to Andy to speak about the genetic counseling perspective and speak more about those clinical trials for GBM.
Thanks, Jessie. That was very, very interesting to learn a little bit about all of that. So first off, apologies if there's any background noise. As Rachel mentioned, I'm traveling here, so I'll do my best to speak up and make sure everyone can hear me. But for those of you who haven't met me, which would be odd if not, I'm Andy, and I'll be speaking a little bit about the biology as well as the genetic counseling aspects of not just GBM, but oncology in general. Next slide. So we'll go through a couple of different items as we're going through the outline. So we'll start with the typical presentation of GBM and more broadly in any oncology indication, and the red flags as well as the family history that a genetic counselor or any other clinician would look for that may indicate further assessment. And then go over the typical conversation points and items that are discussed in an initial genetic counseling consultation, followed by the differential diagnosis of those that might overlap with GBM or other types of brain tumors. Then talk a little bit about what's typically discussed in a post-test genetic counseling consultation. And then I believe we'll finish with going over some of the basics of the clinical trials. So just to start off, this fact here, approximately 5% of gliomas occur with family features suggesting an under-recognized tumor predisposition syndrome. And this follows along fairly similar to most forms of hereditary cancer, and that we know that essentially all forms of cancer are genetic, but not all are hereditary. Typically, we see somewhere between 5 to 10% that we know that there's a hereditary cause. Others, we can note a familial cause without an underlying known genetic finding. But this tracks along with that fairly well. So anytime an individual is indicated for genetic counseling in the space for oncology, there's a number of different red flags that we look for in the individual that can increase the potential concern or risk for a hereditary form of an inherited cancer syndrome. Often we'll see multiple primary cancers at once, especially, if there's bilateral organs at the same time, for instance. You can see that in the kidneys and breasts, or multiple primaries in the brain. Rare histologies. So histology is basically looking at a sample of tissue under the microscope. Different markers are added, as well as other means to basically identify what is the pathology of the change to the cells. And sometimes different histologies than typical may be seen that highly increase the risk for a hereditary cancer syndrome. Going along with this, there's certainly rare cancer types for age or sex. A common example would be breast cancer in men, as well as in the brain. There's something called choroid plexus cysts, CPC for short, that can often be seen in what's called Li-Fraumeni, or the TP53 gene associated with it. Again, pathology, I touched on a little bit there. And then another big piece that's the core of the genetic counseling tool belt is, taking a family history. So seeing other individuals or patterns in the family history, suggesting that there's multiple individuals with a diagnosis of cancer, especially if they're all of a similar type or associated types. And each cancer syndrome may have certain cancers that we know are associated with it. So that will be kind of looked at as well. And going into a little bit more depth there, we'll often see there's specific criteria for each type of cancer syndrome. Some have more developed than others. For instance, we know like Lynch syndrome and some of the hereditary breast and ovarian cancer syndromes have key criteria, but even in the space with brain cancer, there are some. But just generally speaking, for family history, if we see a first-degree relative with a similar tumor or syndrome associated with a tumor, that's typically enough for indication for review or potentially testing. 2+ first-degree relatives with a rare tumor, or 3+ relatives, 2 generations with tumors of same or similar site. And when I say degree, so essentially a first-degree relative to me would be my parents, any children I had, or siblings. Basically, you're counting one out. So a second degree would be grandparents, and so on and so forth from there. And on the left here is a autosomal dominant inheritance pattern. Most, but not all, cancer syndromes typically follow this pattern. Some of that is based on what's called the two-hit hypothesis. So basically, we have essentially for most genes, other than X and Y, 2 copies of each gene, and tumor suppressor genes. So if you have a second copy of that gene, it's able to protect against some of that risk, but at some point the other copy may change in some way, thus increasing that risk. So essentially, they're typically seen. There's a 50% risk of passing this on. So you may see one generation, the next generation, the following generation, having this increased risk of cancer versus a recessive one where it may just be all in one generation. So again, just kind of coming back to that, in summary, as Jessie had noted, 90% of glioblastomas are de novo of unknown cause. So, even with all of this genetic counseling and genetic testing, it's not the norm that we identify hereditary cancer syndrome. So in any case, when an individual is referred for genetic counseling, we like to make sure we're hitting on a number of different elements for the patient. So any type of genetic counseling session, typically the first thing that is done is contracting. So we want to create a mutual agenda of, okay, the individual in front of us, what are their goals? What do they hope to attain from this? That really sets the tone to make sure that we're covering all of that. So that's really step one, to be clear in our communication there. Next, we kind of start an assessment period, which falls into 2 pieces. The first is the medical history. So, typical review systems, head to toe, basically making sure if there's any concerns, ears, eyes, all the way down to the toes, and checking in on that, as well as past medical history, surgical history. Basically, we're looking at big picture. So a lot of specialists will focus on one health system. We're looking, at the full big picture, because there can really be a lot of information in that. So once we go through that, we'll also obtain a 3-generation family history. So we'll typically draw out a pedigree, the circles and the squares and the big family tree, and ask targeted questions based on the indication. If it's oncology, asking about age of diagnosis, pathology, and a lot of detailed information. Oftentimes we'll ask for this ahead of time because it is burdensome to get all of this information, and also it can be challenging to talk about family history sometimes. So having some of that or all of it ahead of time can leave more time for questions for the patients as well. And then once we have all that information, then we'll really look at that, see if there's any patterns going on in terms of tumor predisposition syndrome, if they're hitting any of those red flags, and either personally or in the family history. So once we do that, if there are any suspected syndromes or implications, we'll really discuss those in more detail, or if not, what that also means. And in either case, we always go through the risks and benefits, as well as the limitations of genetic testing. So benefits, obviously, identifying a specific genetic change may impact treatment. It may or may not. As well as just having an answer. I can't overstate how important that can be for individuals to have some type of understanding of, okay, this contributed to the cause. Limitations, obviously, we can only test what we know, and technically speaking, there's all sorts of different quirks to genes. Repeats of the same nucleotide, deletions, duplications, sequencing changes, and each test has limitations in that way. And then risks, of course, anytime we're talking about genetic testing, there's a risk of information being shared too broadly. Insurance implications of what laws, GINA, for instance, the Genetic Information Non-Discrimination Act that's out there, and what is protected and isn't. Typically, health insurance is protected, but there even are some loopholes in that, whereas like life insurance isn't. So we talk through all of that to make sure that they're well informed before doing any testing, if they choose to, and also saying, testing isn't required. It's always an option. Genetic counseling is very non-directive. We'll also talk about the different types of results. So positive and negative are fairly straightforward. Negative means we didn't identify anything that we looked at. Positive can be either, and actually, let me back up for negatives. There's 2 types of negatives, actually. So an informative negative, if we know there's a cancer syndrome in the family and it was negative, that means it was not identified in that individual and reduces the risk. If they're the first person we're testing, it may be an uninformative negative. You have positives where we identify a specific genetic change and can make recommendations off of that. And lastly, variants of uncertain significance. So that essentially means that we found a genetic change, and it has some criteria about it that it is concerning to be disease causing. However, it hasn't met the threshold of criteria necessary to determine that is the cause, which can require some further follow-up and investigation, and it may just be we don't know right now as well. And then we certainly also provide psychosocial support through this whole process. It's a lot of information to process, to understand. There's a lot of impacts to treatment and such. So from the start to the end, we always assess the patient, making sure they're doing well or anything that they need, and providing resources around that as well. And then lastly, based on what the patient and family would like to do, we really assist with coordination of testing. So there's a lot of steps there. If it's a blood sample, a saliva sample, getting that collected, investigating the cost ahead of time. Insurance can be It can vary from institution to institution, from insurance company to insurance company for pre-auth, all of this, and genetic testing, unfortunately, is still fairly expensive. So we do our best to really upfront understand what the cost is so there aren't any surprises there. So when we're looking through the family history, I think it's important to note of some of the more common conditions that we would see and would be concerned for a GBM or a brain cancer in general. So Jessie had actually mentioned two of these in her section. So Li-Fraumeni as well as retinoblastoma. And these are what are called tumor suppressor genes. So TP53 and RB1 they're basically checkpoints to ensure that a cell doesn't divide uncontrolled. And if there's a change in those genes, they increase that risk there. So for instance, with Li-Fraumeni, if there's a change in that, there's essentially 100% chance of cancer. There's still a lot of screening and management that can be done there, but it's important to know that because it really does change management. Retinoblastomas a bit more focused. Typically, you'll see tumors in the eye. Interestingly, if you take a photo of someone who has a retinoblastoma, you may see a white reflection in one eye. And then rarely you'll also see pinealoblastomas, which certainly occur in the brain there. A different type of instead of the tumor suppressor genes are oncogenes, where the overactivity or changes that can increase the prevalence of tumors and non-cancerous tumors as well. So in NF1 and NF2, which are somewhat related, you'll see tumors occurring for NF1 in the brain, nervous system, as well as blood. Whereas in NF2, it's more so focused on the nerves and the spinal cord. But just the mass effect can impact that. So it's still important to be managed appropriately. And then there are some other rarer forms as well. Turcotte syndrome's on there, which impacts the mismatch repair. So repair of the DNA. So you can see gastrointestinal tumors as well as brain cancer. There's also listed some other syndromes, but just based on time, I'm not going to go through all of those as well. So this page here is really just showing the different types of inherited genetic variants, as well as the histology associated with those. So as you can see, certain genes are associated with specific histologies as well as molecular types. So we don't really have to dig too much into this. Essentially, it's just kind of emphasizing that based on if there is a hereditary form, it can impact the potential treatments, potential management of that. So highlighting the value of genetic testing in modifying treatment. So after going through all of that, if an individual does want to go through testing, typically most genetic testing, if everything goes right, the lab takes between 3 and 4 weeks to get back. So in the post-test review, there'll be a couple different results we can get. If it is positive, and even if it's not positive, we'll discuss management at a broad sense. The genetic counselor scope of practice truly is in the genetic side, but we can at least equip a patient with the appropriate referrals to the oncologist or otherwise to make sure that they are getting the care that they need. Oftentimes with these hereditary cancer syndrome, there's an increased surveillance. Sometimes if it is with a current diagnosis, changes in treatment, preventative surgeries, things of that nature, based on the type of cancer that's identified. And then if the testing's negative, we still don't do nothing. So if it's negative, certainly we address the psychosocial concerns there, as well as sometimes we'll start with targeted testing and broadening that further. So there's target panels for hereditary cancer, as well as, broader test, whole exome, whole genome. Obviously, there's pros and cons to doing so. So it really is on a case-by-case basis if there is value expanding beyond that. In the case of the VUS, variant of uncertain significance, oftentimes testing other family members can be a big help there in clarifying that. Sometimes family or mom, sometimes the parents is a good place to start. And supporting an individual through that, and there's psychosocial elements with each family to address there. So we may talk through that as well. Lastly, in terms of reproductive options, PGD is pre-implantation genetic diagnosis. So basically, if there is a known genetic change, we can, or the specialists who know what they're doing with all of that can test the embryo and identify if that change is in there and select an appropriate embryo that doesn't have that genetic change. Egg and sperm donation or prenatal testing during a pregnancy and amniocentesis is one option there, and decisions can be made off of that information. And then certainly, post-test, providing support groups, assessing for the need of mental health counseling is something that I think is really important to provide to each individual. Again, this is a lot of information, and genetic counselors do really take the time to go into detail of all this information. So hopefully, build that level of trust going through all of this, so that they have the unique perspective to be able to assess and potentially provide referrals in those spaces. And then of course also talk broadly about clinical trials as well. So in terms of clinical trials, there's two main categories. So I would say in terms of if a specific syndrome or genetic condition is identified, it can provide value because there's certainly always a lot of kind of clinical trials going on specific to that not even just a specific cancer syndrome, but maybe even a specific genetic variant within that gene that they are targeting. A lot of treatments will focus on that. So having that testing can provide that focused ability to enroll in these clinical trials. Outside of that, there's also non-genetic diagnosis-specific trials based on the type of pathology or histology of the diagnosis. So, just I think a good resource that's typically I will typically look at is clinicaltrials.gov. So, just in terms of GBM, they have a cellular regulatory pathway transduction inhibitor research study, and I don't pretend to know much about that. But in addition, there's a lot of immunotherapy research that is being done using antibodies and vaccines in terms of treatment. But in any case, most cases I will look at clinicaltrials.gov to see what's available so that I can point patients and families in the right direction. And I believe that's all for my section. So I can pause and see if there's time for questions.
I can ask a really quick question, if that's all right. So I feel like for cancer genetic counseling, you usually hear like breast cancer, like colon cancer. Like, I don't know if I've ever really heard of like brain cancer genetic counseling. So I was just wondering if you knew by chance like how common that is. I mean, given the nature of brain cancer, it's a little bit more rare.
So that's a good question. I would say I think just based on the frequency of colon cancer and breast cancer and some of the more common forms of cancer, they tend to have more volume and thus more people focusing on it. But I will say I haven't seen many cases, to be honest, just from my experience. But I think there are certainly tumor boards that specifically focus on neuro-oncology, for instance, and such. So there are specialists out there in that area. But to be honest, from my perspective, I think I do see that bias a little bit.
Yeah. And I just piggyback a little tiny comment that I noticed when I was just looking into some of this myself, is that Lynch syndrome actually does have an increased risk for brain cancers, but it doesn't have a specific number, because it's not as increased as colon cancers and things like that you'd hear about. But it's important as, future genetic counselors to keep those things in mind, because, a patient maybe is the rare one that presents with the brain cancer instead. I mean, I don't know if that would happen with Lynch syndrome, you'd have to say with Andy, but following up off maybe a primary colon cancer or something, if a brain cancer could be another red flag for a family history. Or
it's interesting you actually mentioned that. I shared a diagnosis today of Lynch syndrome, and the question came up about that, and in terms of screening, and it's really just being aware of those early signs and symptoms of neurological concern, and discussing what the increased risks are based on population risks. And there's the difference between population risk and hereditary cancer syndrome risk. It's close, so it's a tough thing to kind of cancel on.
Yeah, I imagine there's like a decent amount of overlap, even though there's of course different like biological aspects of different cancers. I imagine like in terms of genetic counseling style, of course the process is still very similar. So that makes sense. Okay, thank you.
Okay.
On to you.
All right. Thank you so much, Andy. I appreciate it. And yeah, pass it off to Drew.
All right, cool. So it's nice to meet everyone here and everyone who will be watching this on recording, which I imagine there may be a handful. I'm just going to start by talking a little bit about myself and kind of giving an overview of who I am and kind of how my story came to be. And then to just provide a little bit of an outline, I'm going to go into my kind of story on how I got diagnosed, what the progression of symptoms were, when I had surgery, the treatment, and then kind of continuing on until today, which for the last 6 years I've been on a pretty promising clinical trial. So I'll start with some background. I grew up in Akron, Ohio, which is about 15 minutes south of Cleveland. Somewhere along the way during my education, I got really interested in research, which kind of took a few different forms, but I ended up following that to get a degree in political science with a minor in econ at Ohio State. Unfortunately, right about the time I was graduating, I realized that I hated politics. So what I just kind of went back to basics, and I said, what am I good at? And so I started writing content for people's websites, businesses. I built up some clients, and then I got a job at a marketing agency that specializes in healthcare businesses. So the reason why that is relevant is because it goes back to the fact that I've always been interested in biology and like medical research. And I think having a job that has allowed me to do that has made me kind of open up a little bit more about my own health journey and not kind of look at my health very analytically instead of kind of just being like reserved about it. So because we're examining this through the lens of like genetic testing and some factors that may be considered predictive to at least some degree, I wanted to give a quick overview of my own genetic profile, like kind of my background and the factors. So I am a white male, right in the demographic with a slightly higher risk of developing a brain tumor. And kind of with that in mind, I'm a bit of an outlier when it comes to age of diagnosis. I think Jessie talked about how the average age of diagnosis is around 60 years old. I was diagnosed at 23, barely out of college. And then I do have, or I may have a family history. So my dad's dad died when my dad was young, of a brain tumor, and it was, before a lot of the classification was happening, and they could really get specific into what it actually was. But I think based on kind of talking to some people that I worked with in terms of like neurologists, neuro-oncologists, they're thinking that the time when he was diagnosed and kind of how long he survived after that suggests that it may have been GBM, but just wasn't classified as such at the time. Moving on. So I have kind of a long story, and I apologize that I'm mostly reading off of paper because I had to really kind of dig back into the memory bank to get kind of a recollection of a lot of this information. But in early 2015, I was kind of working towards completing my last semester of undergrad. I started to notice minor things that didn't really seem concerning at the time. Things like, I was like tripping a little more often with my right foot because I wasn't lifting it up high enough when I walked. I was getting lightheaded from like I've always been a big coffee drinker, and then suddenly I would drink like half a cup of coffee and get really lightheaded. I started to get these episodes where I just couldn't form words for like a few seconds, maybe 3 to 5 seconds, and then after it would be completely fine. And in hindsight, those sound pretty severe, but I kind of look back and think about how like I was going through a lot of changes in my life. I was getting ready to graduate. I was trying to find a job, and I kind of really dismissed the symptoms as having to do with those life changes. But over the course of the next year, the symptoms worsened. The bouts of aphasia, which would later be considered or identified as seizures, became more frequent and kind of longer lasting. I stopped being able to write coherently just due to a general kind of lack of clarity in like cognitive function. And so since that was how I was making money at the time, I kind of had to stop working for the most part. And that led to me moving back with my parents in Akron. I had been living in Columbus before then. I actually went to the doctor for depression and was put on medication. And I started to experience chronic pain in my neck. And as it turned out, that was caused by the mass in my head causing me to strain. So sometime in September of 2016, I went to the hospital, and I don't actually know why, thinking back, which is pretty amazing. I think I just woke up one day and I felt bad. And I was like, I just want to get some answers and some peace of mind why, like, clearly this is not normal. I kind of explained it away and tried to dismiss it as normal. But eventually I just kind of realized that I needed someone to take a look at it. So I drove myself to the hospital. I checked myself, or I got checked into the ER, and they started doing scans pretty immediately, which I guess in hindsight was a sign that they thought something was pretty serious. So sure enough, I did a CT. They found a mass roughly the size of a tennis ball in my kind of covered my left frontal lobe, a region of my left frontal lobe and motor cortex. The tumor is actually on top of a large cyst, which was fortunate for me because the swelling from the cyst was pushing on my brain and causing symptoms earlier than if it had been on the tumor on its own, which is good because they caught it earlier as a result. So understandably, they wanted to do surgery right away. I had to wait a few days to get it scheduled, so I was checked into the hospital and in intensive care. I had an 8-hour craniotomy, which is the removal of a brain tumor, with assistance from a device called an iMRI. It's an MRI machine that takes images in the operating room. So they can kind of use that to take scans during the operation, which I kind of credit as another reason why they were able to do such an effective and ultimately lengthy surgery. I think Jessie mentioned earlier that it's not possible to completely remove just gliomas in general because they kind of spread throughout the brain and work their way in through like the cracks and stuff. But I think they told me that because of using the iMRI in the operation, they're confident that they got like 99.99% of it. So they took a tissue sample during the surgery to be biopsied, and a week later the biopsy came back. The tumor was mostly low grade, but a tiny portion of it was grade 4. So since tumors are classified by their most severe region, officially it was a grade 4 glioblastoma. So my treatment was pretty much considered the standard of care. So in my case, that meant most people who have GBM get a combination of chemotherapy and radiation. I did 6 months to start. So radiation was every day. And then 2 times a day, I would take an oral chemo drug called Temodar. And then after radiation, 3 months of maintenance chemo, which consisted of taking that same drug on a lighter dose, 1 week on, so every day for 7 days, and then the ensuing 3 months off or 3 weeks off. I think I probably considered I experienced what you would probably consider the classical symptoms of treatment, like side effects of treatment. So loss of appetite, hair loss, pretty severe nausea, headaches, and dizziness. I think I was told at the time that the treatment for the oral chemo treatment was a lot gentler than when you see kind of depictions of people getting like the drip chemo treatment, and I'm sure many people have seen that with their own family members and stuff. It's pretty rough. So I'm kind of lucky to have avoided that and dealt with some severe symptoms, but not like debilitating symptoms. I was still able to live a fairly normal life. To which I will say I didn't really want to face the prognosis at the time. I just kind of said, I don't know how long I have, so I'm going to make the most of it. Mainly I traveled. I had some connections with people who had family or friends who lived in like exotic places. So I took the opportunity to travel as much as possible. And then talking to my neuro-oncologist, she said, I just learned about this new study that they're opening up applications for at the Cleveland Clinic. At the time, actually the hospital where I had surgery at was in Akron, but it had just been purchased by the Cleveland Clinic network, so it had been acquired. So it was internal referral, which made it way faster and easier for me to start doing the testing to see if I was eligible for the trial pretty immediately. So the study is called Survaxum. It was developed by a highly regarded cancer hospital in Buffalo called Roswell Park. It was offered to a select number of other hospitals, including the kind of several hospitals within the Harvard Medical Center network and the Cleveland Clinic. So I went through a series of blood and genetic testing to see if I was eligible. I added some of the major eligibility factors here in case people are interested, just for reference. But I fit the specifications for the trial and got started, I think the week after the results came back. So the study itself, kind of the process of the study, it was a series of vaccinations in which 2 subcutaneous injections make up a single dose. So there's the actual vaccine, which was something complex, emulsified in a solution, and then something called sargamostim, which looks a little bit like Elmer's glue, and that's a little off-putting, but it essentially stimulates the immune system so that the vaccine has a better chance of doing what it's supposed to do. So continuing kind of the overview of how it worked, treatment started as soon as the swelling in my brain went down from the radiation. That's just so they can get a good baseline. I think when we're talking about a study, obviously that early data is really important. So they're not going to get any baseline scans or anything that would be something that they would compare to until there's relative stability in the area being imaged. For the first 2 months, I was at the hospital once a week for imaging and blood work, and they just gave me 4 doses in that time. And actually, I got so tired of making that 50-minute drive at like 5 a.m. for really early MRIs that I just moved up to Cleveland, and that's where I live now. And then once that initial period was over, they scaled me down to 1 visit per month, where I got a vaccine every time I was there. And then what is kind of still the status quo today, which is I go in every 3 months or so to get new blood work, scans, and injections. So I actually, before I started putting this presentation together, I wasn't planning on talking a lot about the results from the study. But as I was starting to compile my slides, I noticed that results were actually published this year in June in a journal, and then they were exhibited at a conference at the beginning of this month. So I thought I would share. So this first table shows that the PFS, or progression-free survival, just means like the amount of time you go without having a recurrence. So you keep going to the hospital, your scans are continuously stable as long as you have that kind of routine going. And they're not like, hey, we noticed a little bit of growth in the tumor site, the resection site. You are considered to be progression-free. So PFS means the subject is still alive, but hasn't dropped out of the study due to having a recurrence. the median PFS for this type of cancer just generally is 7.4 months. On this study, the median was 11.4 months, and 22% or over 22% of the trial participants were still progression-free after 3 years. And then if you flip to the next slide, we can see more outstanding numbers where the overall survival is just a hair under 26 months compared to a general median of 12.8 months. And I'm within that, so that there's a data here for the methylated group and the unmethylated group. That's just basically talking about how the MGMT gene is coded in the patients. Unmethylated people have, just in general, a much shorter estimated survival. So I'm part of the methylated group. So my kind of cohort, 56.3% of trial participants were living after 3 years. That's kind of when they stopped recording data. But I recently hit the 6-year mark, and they've told me that just generally they're less than 4 people, or 4% of people make it that far. And then you'll see kind of on the final slide, I just summarized the data for reference and to show that patients in this trial do tend to have significantly improved results versus averages. With that in mind, I don't really think I'm like a medical marvel or anything like that. I don't fit the mold of a standard GBM patient. And a lot of research shows that people who are diagnosed when they're young and are in relatively good shape and had the tumor kind of discovered early, like it was in my case, have a better chance to beat the estimates. So to kind of wrap up everything before I stop talking, I think this study and kind of my case in general goes to show that if you're in a situation where you're talking to patients about their risk of developing any type of disease, like Andy kind of emphasized, it's really important to let them know that there are options, especially when the prognosis is a little bit more grim, like in this case. Like, people, I think, would see the general numbers. I think I'm not alone when I say the first instinct when you get news like this is to just look up, how long do people live? And you see that number. I think it's 7.4 months or 12.8 months, 7.4 before progression, and then 12.8 just total. That's kind of like, it's really grim and kind of can make you lose hope. But I think that being able to be in a position to advise patients and say, hey, like, I'm going to help you find something that may kind of increase your opportunities to live the life you want to live as long as you can. I think that's really beneficial, and I'm like really lucky to have had that opportunity with somebody who was on the health side, not the counseling side.
Thank you so much, Drew. That was all excellent. And so before I say anything else, I'll go ahead and give the opportunity for anyone to ask questions for those who are with us live.
I have a question. Can you hear me? Because I needed to leave the house, so I'm outside.
Yeah, I can hear you.
First of all, I wanted to say thank you. That was a really interesting presentation. All three of you. It was really interesting. I learned a lot today. And I wanted to ask Drew, and I hope it's not triggering. If it is, feel free to just say no and not answer that. So when you were diagnosed, I'm just curious, what was kind of the first thing that ran through your mind? And at what point after the diagnosis did you feel like, okay, I'll get over this. I have hope. I have resources. I have options. I'll be fine.
Yeah, so I think in general, and I'll say this for people who are maybe watching this on the recording too, just in general, I'm like pretty much an open book about this stuff. So if anyone wants to like connect on LinkedIn or send me an email with additional questions, I'm happy to answer anything. But to talk about like my experience and kind of my mindset when I got the diagnosis, it was one of those things where like everyone is like, oh, that type of rare cancer that always happens to someone else. It'll never happen to me. It's always something that like you read about in like medical journals or like in like puff pieces or like in Sports Illustrated when they talk about like a football player who had leukemia or something like that. And then it suddenly becomes very real when it happens to you. And I think Rachel will tell you that I'm pretty like apathetic about things in my life. So I didn't take it that hard at the time. I was just kind of like, whatever it is, it's like that's how it's going to be. I think actually my parents took it way harder than I did, and so I felt like at the time I was kind of having to like stay kind of strong and even keel for their benefit. But I figured like I had all these plans, that stuff I wanted to do, travel I wanted to do, that I was like waiting for the right opportunity. And so I think my first thought was like, well, if I only have like a year, like right now, I need to go do a lot of that stuff. And then I came back and I felt a lot more stable, and I was talking about the study, so I was kind of distracted. So I don't think it ever was really like, for me, like a really kind of devastating piece of news. I think I kind of took it in stride from the beginning.
And I would say, just to piggyback off that's kind of my experience watching you go through it. I can't say where there was like that transition between like kind of more of the like, not going to project depression onto you, but more of the negative apathy side of things. And then there was at some point, I don't know when in the timeline, it just seemed like, okay, things are still going okay. And I feel like I noticed that, although you seeking the fun experiences and the stuff at first is super valuable, it was good to see you getting back to like some of your daily things that you enjoy that maybe didn't seem as valuable early on and whatnot. So, but
Yeah,
I would say you definitely took it very strongly, and then almost to the point where talking about like your parents being difficult, a lot of your responses had to do with what you were doing for them rather than for yourself.
Yeah, and I think it's weird to think back on, because I struggled with like the having an active tumor so much more than I struggled with like reacting to the diagnosis. Where when I went to the hospital and they found the mass, I was like very relieved. I was like, okay, well, like there's a reason why I feel this way. It's not just happening, because like, as I'm sure a lot of people that you guys work with feel every day, they're looking for answers and they can't find any. So that was a big relief for me. And then I tell this to people because I do write for a living, and that involves a lot of concentration and focus. And it was kind of like scary when I lost that ability. As soon as I woke up from surgery, like in the recovery room, I felt like I could like organize my thoughts again. And that was such a relief.
One other thing I'll say, it's funny. I found this like old cell phone the other day, and there are like random old pictures on there, and there were some of like some hands that you had drawn, and I remembered that you had told me in the beginning, and I was trying to think of things to cheer you up, because I know you like to draw, and I remember when you had mentioned that you didn't even want to try to do it afterwards because of the way that you felt during having the tumor, like kind of taking those skills away and whatnot. So.
Yeah, I mean, interestingly, I still have like some motor skills issues after surgery, and it's probably not due to the cancer. It's just because it's like a cranial resection is like considered brain trauma. But like I had been like an avid baseball player throughout my entire childhood and early adulthood, and I completely like lost the mechanics to throw a ball, which I think like a lot of that, I think a lot of people would be like messed up by those changes. I just like think it's very interesting.
Drew, I have another question. Yeah, I have one more. And I think that's my last one. Are there any healthcare providers throughout this process who you remember as, what should I say, like good or bad? Like anyone who said something that you remember being shocking in a bad way that you never want to hear again, or any other provider who said something that really calmed you and helped you cope with this?
Yeah, I'm sure if you had asked me like 5 years ago, I would be able to answer very specifically. I'm lucky enough to be born in a part of the country that has like world-class hospital systems. So even like the hospital I went to in Akron was part of the Cleveland Clinic system, and the doctors were all great, and my neurosurgeon was great until he just kind of ghosted me and moved to New Hampshire without letting me know. But I think for the most part, the people don't realize when they go into like a healthcare setting how like regular it is for the doctors you're talking to and stuff. So I think that's the most like it's the biggest adjustment when you're suddenly like you haven't really been involved in healthcare or been in a situation where you needed to rely on doctors, and then suddenly you have to, and everyone's kind of speaking about your like life-changing case as if it's just like another day at the office. Like that kind of took me aback, but I don't think there were anything that stood out as like significantly positive or significantly negative.
Got it. Thank you. I do hear a lot. So I'm from Israel, and I do hear a lot in Israel about people with certain cancer types who cannot find treatment in Israel, so they come to America for treatment, but that's very expensive and it costs them in the millions, you know, and so they look for donations. So I think when you said you're lucky to be in the area where you can get treatment,
Right.
That's amazing.
Yeah, actually, Cleveland is one of the top hospitals. I think they do some kind of marketing or assistance program for people who are international, but they bring in tons of like, and most of them are wealthy, kind of like you said, but they bring in tons of people from like the Middle East and all over the world to come and get treatment for certain cancers and heart problems. So having that in my backyard was kind of a lot of things lined up in this situation to have me be here where I am today, and I feel fortunate for all of it.
Yeah, I had a quick question. Thank you again, Drew, for sharing about your experience. And it just from the sounds of it, it sounds like you're doing a lot better than that period of time in your life. So really hope that holds up in the future as well. But my question was, you kind of touched upon like around the time it sounds like you got the diagnosis, you had like traveled and done kind of like maybe like stereotypical things of like, you know, you only live once. But is there any kind of like long-term lessons that you've learned or things that you've like really decided um, about your own life if you like try to live it any differently as a result of this experience?
Yeah, I mean, I wish I could say some big epiphany that I've come up with. I don't know that I'm like a lot of people get a lot of like hope and like mental wellness from like support groups. I'm kind of the opposite. I've mainly tried to live and like live like a normal person instead of like thinking of myself as like, oh, I'm a patient. Like I try to stay away from that mindset as much as possible. So I'm really not thinking about myself as someone who has this disease and who's living through it. But I mean, I do think that like it kind of gives you some perspective. I think like I was talking about during my presentation where I was like, or maybe that was an answer to to one of the questions previous, where you're like, this, it's something that happens to someone else until it's not.
Mhm.
And so I think it's like, don't take anything for granted. Like, take care of your health, especially when we're considering all this through the lens of like genetic factors and predisposition and risk factors. Like, just maybe like try to take care of yourself because you can't take it for granted.
Yeah, for sure. Thank you.
I have a quick question. Drew, thank you again for like sharing your experience and just like taking time out of your day today to be with us. But my question is like given, you know, we talked about glioblastoma, it's one of the most common forms of like brain cancer. Is there like any advice you would give to anyone who's also in a similar situation as yourself? Or
Yeah. So I have been pretty active. Like there's like online communities of people who are like going and doing searches and looking for results, like mainly on Reddit. And I always tell people just like go to clinicaltrials.gov, speak to people who are like in the know about what kind of studies are going on, find a contact at like a high profile healthcare institution, even if you don't have the resources to travel or relocate or seek treatment there, because like having access to that network of trials was like ultimately what has me talking to you today.
thank you. Thank you for saying that.
And I'll repeat myself that like I would have no issues. Actually, I'm happy to answer any questions that people have. So if something pops up in like a week from now or a year from now or whatever, my email's right here. I don't answer it or I don't check it as much as I could because I'm busy with work stuff, but I will see it eventually.
One question I was going to ask on behalf of the group, just because I think that the answer in your experience and your perspective is interesting and important, especially because brain cancers, like we talked about, are often diagnosed in men or people born as male. The age difference is another factor where, older than 60, you might not necessarily think about reproduction or whatever, but I wanted to see if you could mention if it had been addressed prior to the chemotherapy and radiation about your own, if they wanted to freeze sperm or, save it, or if they even brought that up or mentioned any, what your options would be.
Yeah, I mean, I think every time I was at the hospital, they would ask me two questions. One was, do you want to talk to a social worker or a counselor? And then the second was, do you want to talk to somebody about like reproductive like information? And I like part of me wishes I had said yes to the second question, just to have that option. Although the radiation in the spot that they gave it to me, it was kind of far from the parts of the brain that like control the endocrine system, so that like if I tried to reproduce, they would be pretty low risk. But no, I never actually pursued any of those avenues. I was never really interested in having a family. So that's kind of like, I figured it's kind of like not very responsible to have such a short prognosis, even like regardless of how long I last on it, and then also just be a parent,
Yeah, and I think everybody's experience is going to be different there, but it's good to know that they brought it up consistently, at least, because especially with like the rate of the craniotomy, I don't know if it could also be different with different parts of the country or systemic racism and stuff, whether or not patients are even offered those kinds of services prior to receiving radiation, or if they're told, oh, you can't have kids if you have this radiation, or oh, it's okay, it's far enough away. Like even sharing that information up front, I think is definitely important.
Yeah, I'm like well aware and kind of will acknowledge my level of privilege in the whole process, like my comparative resources and access to quality care and access to like just really expert doctors that a lot of people don't have access to, which is why like I think if there's anything I've become more interested in, like with my research and stuff that I do on the side, it's like healthcare equity, making sure people in like less advantageous situations have the access that they need to the same types of resources.
Yeah, and I think that's what's really what I'm so glad with this presentation has shared to future genetic counselors is, if you get that patient to genetic counseling, you might be the only provider that is there to give them those resources or let them know that they can get access to them. The thing you mentioned about travel is very important. And I know that Mark, my fiance, is always, when he just got a new job, but at the hospital, coordinate travel to Cincinnati Children's for people from all over the world. And oftentimes those types of things are donated or and they have assistance. So you really can't know until you ask. And a lot when especially if it was someone by themselves without support going through a brain cancer diagnosis, having cognitive challenges already, you can imagine that having to look up clinical trials on their own or advocate for their own reproductive health and whatnot can be a huge challenge. So
yeah, and thanks for mentioning that, because I wanted to add that for like if you're working with low income patients, like oftentimes a clinical trial is just what they need, because there's so much funding that like to do this research, the institutions that develop it make so much funding available to the hospitals just to kind of, because it's like it's a rare disease, they really need people in this trial to get significant data. And so like there were times over the past few years that my MRIs were actually too frequent for my insurer to cover all of them. So they would cover like every other one. And if it wasn't for the trial, kind of negotiating it down and picking up some of the extra costs that like went above my co-insurance, then like I would have had a hard time affording a lot of my care. I would have been able to do it, but some people don't have that same option.
You just reminded me too that at the time when you were 23, and I remember we were talking around the time you were about to turn 26, and there was so much panic around losing your parents' insurance and losing access to getting those MRIs every 6 months or whatever. And I know you were really thankful to get the job that you had that gave you health insurance, which is great. But yeah, for people without any health insurance or that are on, have bad, I mean, let's be real, bad health insurance from their work that isn't covering almost anything, then supplementing with clinical trials is a real kind of a good way to get care without having to finance it yourself per se.
Yeah, I did spend a year on like the marketplace insurance, and while it was much better than having no insurance, obviously, the premiums were about like 2 to 3 times what I'm paying now through work. So definitely also a thing that I'm passionate about. Make health insurance more affordable, please.
Yeah, definitely. Okay, I was going to say, if you just wanted to briefly talk about kind of your experience with the 5K that you just ran and kind of your connections with Head for the Cure, I think that'd just be good to share to highlight the organization to some of our students.
Yeah, so I mean, it seems kind of selfish to a degree that I only raise money for brain cancer causes, but I feel like, this one goes directly towards funding things like in the department where I get my treatment at Cleveland Clinic. So it's kind of a personal cause for me, and it's the only I try to do a lot of 5Ks over the course of the year just to kind of stay in shape. But this one called Head for the Cure, I think they do like 10 cities over the course of like the fall. But every year I try to raise money for it. I think I started it like maybe a year after I started treatment. So my neuro-oncologist was like, hey, the hospital does some work through this organization called Head for the Cure. It's a really small nonprofit, but based outside of, I think, Kansas City, somewhere over in that area. So if you're looking for an organization to get involved with, I mean, donate to somebody who is doing one of the runs or donate directly to the organization. But I try to stay away from those like very like bloated charities, like the ones who are like, oh, we're all about awareness, and then they don't actually give any money to research. They just like recycle it through the marketing. This is not that. So I feel like it's a pretty good cause.
Great. And good point about the knowing where the money goes for the charity is definitely a benefit. All right, well, with that being said, as mentioned many times, emails have been on the screen, so please feel free to reach out with any questions to any of us. But thank you again, Drew, for sharing your experience, and thank you to Jessie for all of the educational background, and Andy as well. Was exactly what I was looking forward to seeing tonight, and I really appreciate it. And thank you again.